I am Dr. Ted Barnett, founding president of Rochester Lifestyle Medicine Institute, and it's so great to have you all here. Yeah, tonight we are going to be discussing some, at least one really interesting case presented by Pharm.D, and we have an exciting panel with two Pharm.Ds on the panel, plus our regulars, Dr. Melissa Sundermann and Dr. Bob Breakey. At about 7:35, we'll start the case presentation. Hopefully we'll be done with that by 8:15, so we can have a good 15 minutes of discussion. At 8:30, we will officially end this conversation, and those of you who've stuck around long enough will get you'll get your link to get a free CME for attending after you fill out a survey. And then we're going to go 10 or 15 minutes in the lobby if there's a conversation still going, which sometimes happens. We also have free CMEs, including the one that you're attending tonight, and you can also get that information on your website. Sorry, at our website. If you look at, if you want to go through one of our programs live with patients, you can also get receive 10 CMEs for going through the Jumpstart or through the LIFT program. So I'm going to just skip through this. Although if you want some more information about how to work with us, please contact Brian Bell. So that's brian.bell@rocklifemed.org. So our guest tonight who's presenting, which of course she has the hard job, Davena Norris, is a pharmacist and faculty member with the Southern New Mexico Family Medicine Residency Program. She works collaboratively with family medicine residents, faculty, and other team members to care for patients in both the hospital and outpatient clinic. And as a board-certified lifestyle medicine professional and a pharmacist clinician, one of her greatest passions is working with patients living with diabetes, obesity, and other lifestyle-related conditions. She has other teaching roles, including program coordinator for a pharmacy residency program and preceptor for 2 colleges of pharmacy. And her current goals are to increase lifestyle medicine education for her colleagues, residents, and students. And we have 2 other guest Pharm.Ds. This is all on our website. Please take a look at the site because I want to get to the case. But if you go back to the announcement of the event, you can take a look at that, or you can take a picture of this screen and read it later. And then Dr. Breakey and Dr. Sundermann are regular panelists. And they've been doing this now since we started over a year ago. And again, you know them, and their bios are available at the event. Our event is DipACLM medications, a case presentation. Pharmacists using lifestyle medicine to enhance deprescribing in type 2 diabetes, with case presenter Davena Norris, Pharm.D, PhD, DipACLM, BCPS.
So welcome this evening. I am really excited to be able to join this team and this great panel of other Pharm.Ds and MDs to discuss the pharmacist's role using lifestyle medicine to enhance deprescribing in type 2 diabetes. So disclosures, I have no conflicts of interest to disclose. However, I do spend a lot of time out on the trail with my husband and my dog, and that's where I tend to do a lot of my thinking and reflection. And so you can blame some of the content of this presentation on that time spent on the trail. So by the end of this presentation, we're hoping that you will be able to discuss how pharmacists trained in lifestyle medicine can enhance the care and deprescribing for patients with type 2 diabetes, as well as be able to illustrate how incorporating 2 of our pillars of lifestyle medicine, nutrition and movement, improves diabetes care. So I thought I would start off with just a quick background of where I've come within my career and how I found lifestyle medicine. So I got my Doctor of Pharmacy from the UNM College of Pharmacy in 2012. And then following that, I completed a PGY1 residency program in Tucson, Arizona at the VA there. And then was very fortunate when I finished my residency to get hired on as a clinical pharmacist at Memorial Medical Center, which is where I currently am now. I primarily round in the hospital on the inpatient side, but then I also see patients in the outpatient clinic and am involved with both our family medicine and pharmacy residency programs. Shortly after starting, I did get my certification or licensure as a pharmacist clinician. And I wanted to mention that because in the state of New Mexico, that's the advanced practice certification that allows pharmacists to prescribe and manage medication therapy, order labs, etc. And around this time, one of my colleagues and I also helped to start a pharmacy residency program at Memorial Medical Center. And I bring that up because it has allowed me to work with pharmacy residents as well. So for a period of about, 5 years, I worked as a pharmacist clinician, managing a variety of different conditions such as diabetes and hypertension. And as probably many people have experienced in their career, after seeing so many cases of chronic conditions, so many young people admitted to the hospital with diabetic foot infections, et cetera, I really started to question, why, what is going on? And it was a lot of those questions that eventually led me to lifestyle medicine. Also, I have what I'm going to call my ground zero patient. And this is actually the patient case that I am going to go through today, that really helped show me the importance of nutrition, physical activity, and the other pillars of lifestyle medicine. And so after that, I really kind of dove in. I attended a few conferences. So I went to the International Plant-Based Nutrition Conference in 2019. I also completed the eCornell Plant-Based Nutrition certificate online. At this plant-based nutrition conference is actually where I learned about the American College of Lifestyle Medicine. So I joined shortly thereafter, completed the board review course, attended my first meeting, and sat for my board exam in 2020 and became certified as a lifestyle medicine professional. And so really a lot of this education has helped me to improve the care that I provide my patients. But up until this point, a lot of what I've done has been on a one-on-one patient basis. And so now my goals moving forward are really to increase education within our residency program, as well as potentially start a more intensive lifestyle medicine program. So I just wanted to share that so you could kind of see my journey as a pharmacist and how I became involved in lifestyle medicine. All right, so let's go ahead and jump into our patient case. And he is JP, a 64-year-old cisgender man. He was originally referred to me for management of type 2 diabetes in 2017. And he was actually referred by one of our faculty physicians within our residency program. And at the time, both the patient and our faculty family physician were extremely frustrated because this gentleman, his A1C was very elevated at 9.7%. And his glucose readings fluctuated tremendously. So he would have episodes of hypoglycemia ranging up into the high 200s. And they had, tried many things. He was is a retired military gentleman and is probably one of the most adherent people that I have ever met. And his family physician described him as such. And so they were really confused as far as why his diabetes was so poorly controlled, despite him taking his medications as he should, tracking his blood glucose as he should. So during my first visit, of course, I collected a history. His past medical history was pretty simple. Type 2 diabetes diagnosed in 2007, hyperlipidemia, and seasonal allergies. For medications, he was on a basal bolus insulin regimen, so Lantus 46 units at bedtime. And a month prior, when he had last seen his primary care provider, because of his elevated fasting glucose readings, she had actually instructed him to start titrating up his insulin by 2 units every couple days until he got his fasting readings down under 150. He was also on Humalog 15 units before each meal, metformin at max recommended dose, a statin, and aspirin. So here were his vital signs during the initial visit. I just want to note that his BMI is in the normal range. Blood pressure pretty well controlled, did no previous diagnosis of hypertension. Serum creatinine normal, LDL 76 on a statin. And here I included what his A1C readings had done over the past several years. And so you can see for a short period of time between maybe 2014 and 15, he was reasonably well controlled, but overall, as an average, his A1C was pretty consistently elevated. So during that initial visit, of course, as a pharmacist, I wanted to confirm that he was storing his insulin correctly, administering it correctly. So I had him bring it, kind of show me how he would draw up his insulin, how he would administer it, and did confirm that he was doing it correctly, as well as confirmed good adherence to his medications. His blood glucose log was listed below. He was consistently checking his fasting glucose, and those ranged anywhere from 146 to kind of low 200s. Occasionally would check after breakfast, and the time that he did, he was actually a bit hypoglycemic. And then you can see his postprandial readings after breakfast, again, a few episodes of hypoglycemia, and still mostly elevated after dinner, but you can see a wide range of readings here. So during that initial visit, I went ahead and made a few adjustments to his medications. I did, since his fasting readings were still elevated, had him continue to titrate his Lantus up and have him continue to do that on an outpatient basis. And since he was having postprandial hypoglycemia with breakfast and lunch, I did ask him to lower his Humalog dose with breakfast and lunch and keep his dinner dose the same. During that initial visit, I did collect a history on diet and exercise, but I will say my understanding of what to do with that was pretty rudimentary at the time. So as you can see on this, and actually I'll mention, he mostly prepared his meals at home, ate out very rarely, and it overall was trying to limit his carbohydrate intake because he's, been told that elevates his blood glucose. So for breakfast, he was having 5 strips of bacon, was having a glass of juice and 3-grain waffles. And you can see throughout the day, largely meat or dairy, very little in the terms of fruits, vegetables, beans, or anything else. But of course, when I initially collected this, I thought, oh, that's a pretty decent diet compared to many people on the standard American fast food diet. So I didn't really think too much of it at the time. He was a very active person and was riding a stationary bike every morning. Also very active out in his yard during the day. He's a gardener. So overall, I felt like his lifestyle was pretty decent. All right, so I'm going to walk you through kind of how his story progressed. And I'm going to start by sharing with you how we managed it, really focused through the medication adjustment lens. So after that initial visit, he came back a month later. He had already titrated his Lantus up to 70 units at night. He did not adjust the Humalog like I had asked him to because he was still seeing some hyperglycemia. So he had left it at 15 units before meals. And his fasting readings hadn't really changed very much, averaging around 190. Postprandial were still variable, and he was having a few episodes of hypoglycemia. So really my assessment, although it didn't completely make a lot of sense to me given his BMI, it was that this patient had some pretty significant insulin resistance and that I would try pioglitazone to help improve his insulin sensitivity. Now, also keep it in mind, this was a little bit before the SGLT2s and GLP-1s were more widely used. But anyways, I started pioglitazone and asked him to go ahead and decrease the Humalog dose with meals since he was having the postprandial hypoglycemia. All right, so then a month later, comes back, readings really hadn't changed. Now, I wasn't very surprised about this because we know that pioglitazone can take a while to start having an effect. So I thought, let's be patient, let's give it a little bit of time. I increased his pioglitazone up to 30 milligrams. The next month he comes back, so he's on the pioglitazone 30 milligrams. And by the way, I didn't include it in here, but he's still on metformin during all of this. He had increased his Lantus a little bit further, still not really seeing any improvements in terms of his averages. His average fasting was 205, and unfortunately, his hemoglobin A1C had increased up to 10.6. So my plan at this visit, I thought, well, the pioglitazone's really not working. We've given it a 2-month try. I haven't seen any result yet. So let's go ahead and try a GLP-1 agonist for him. The one that was covered by his insurance was Bydureon, so we went ahead and started that. And he was getting pretty frustrated with his Humalog with every meal because he was having such variable readings after. So my hope was that once we started the GLP-1 agonist, that maybe we would be able to get rid of the mealtime insulin. So a couple months later, he comes back. He had continued to titrate his Lantus up to 86 units. He is now on the Bydureon. His readings actually have improved some, averaging fasting around 138, postprandial, some improvements. But unfortunately, he's experiencing some effects of the Bydureon that were concerning to him, specifically the injection site nodules. And so at that visit, I had said, your readings are looking much better. Let's try to stick with this. But then 2 weeks later, he actually chose to stop the Bydureon because of those injection site nodules. And also he just didn't have any appetite. And remember, his BMI kind of being in that normal range, he really didn't need to necessarily decrease his weight. So by December, his A1C had improved marginally down to 9.6%. So basically a whole year had gone by, and I hadn't made very much progress with this gentleman. I'm really honestly surprised that he even kind of stuck with me. By the beginning of 2018, he's on Lantus 88 units. We had switched his Humalog over to doing a certain number of units per serving of carbs rather than a set amount, so that he could have some flexibility, and really no improvement. So this is kind of where I said, all right, we have to stop. Something is not going right here. I reconfirmed administration. I even called one of my colleagues at the University of New Mexico and said, have you ever heard of anybody just not responding to Lantus whatsoever? Are there antibody formations? Asked all of that. And then we got to thinking, well, is he getting too much animal protein and fat in his diet, and really not enough of those plant-based foods? So just as a reminder, here was his diet. So bacon for breakfast, no sugar added yogurt, sandwich without the bread, turkey burgers, chicken breasts. So quite a bit of animal protein and fats, but very little in way of fruits, vegetables, etc. So this is when I finally decided to dig into the literature. And so I came across a few review articles, such as this one by Dr. Bernard, and this one by Dr. McNacken. And these are, by the way, if anybody hasn't read these, I really encourage you to do so. But these articles do a really nice job of reviewing the data that actually shows that meat increases the incidence and prevalence of type 2 diabetes, and that there's actually several large cohort studies that demonstrate that, including the Adventist Health Study, which many of you may be familiar with. But this was a very large cohort study that examined the disease prevalence by different eating patterns and an overall health conscious population. So the Adventists tend to be very health conscious anyway, minimal drinking, smoking, stay very active, etc. And among these 61,000 individuals that were assessed in this study, they found that the prevalence of type 2 diabetes decreased in a stepwise fashion with each reduction in animal products. And after adjusting for BMI and other variables, and you can see this over on the right, that those who included no animal products in their diet or vegans had half the rates of type 2 diabetes compared to non-vegetarians. So I will say that this was complete news to me. It was a shock to me. I grew up in the kind of mantra that diabetes is all about carbohydrates. So this definitely sparked my interest and wanted me to learn a lot more. So a few other examples of some cohort studies that have looked at this, of course, are our Nurses Health Study and Nurses Health Study 2, and our health professional follow-up. And in this analysis, they tracked eating patterns and stratified them based on an overall plant-based diet index. And data from 4.1 million person years of follow-up actually revealed that those that were the most adherent to healthful plant-based dietary index had a 34% lower risk of developing diabetes. They also found that simply substituting 5% energy intake from animal protein with vegetable protein is associated with a 23% reduction. So I took this news back to my patient and I said, I think I figured out what is going on. I don't think it's the medications. I think it's actually your diet. And so I talked to him about the impact of animal protein and fat on diabetes and insulin resistance. And we started to develop a plan to incorporate more of those whole plant-based foods and reduce the animal protein and fat in his diet. And so keep in mind, he was actually very much likes his meat and has been told all of his life he needs to avoid carbs. And so this was big news to him too. And of course, he was a little bit skeptical. So the plan that we agreed on is he would start with dinner and reduce the portion size of his meat and replace that with some plant-based proteins such as beans. And I actually asked him to go ahead and add to his meals some vegetables and fruits such as berries, pears, sweet potatoes, broccoli, and cauliflower. The patient is also very much of a numbers person. And so I knew this about him. And I knew that he would also track his meals. So I asked him to track the grams of protein and fiber per meal. And I asked him to keep his daily protein at about 0.8 grams per kilo per day. So for him, it was about 60 grams per day. And then I also asked him to ensure that he was getting at least 30 to 40 grams of fiber per day. So this was our initial plan. So that leads me into our first poll question for the audience. So I want you to imagine that you're in the role of the provider right now, and considering these agreed upon dietary changes, what changes would you make to JP's insulin today? A, no changes to insulin today, but ensure close follow-up. B, increase dose of bolus insulin because he will be increasing carb intake. C, empirically lower bolus insulin to prevent hypoglycemia. D, empirically lower basal insulin to prevent hypoglycemia. E, empirically lower both insulins to prevent hypoglycemia, or would you do something different altogether? So I'll say there's no exact right answer, but I'd just like to hear from the audience what your opinions and how you might manage that.
So what do you think, Dr. Norris?
Yeah, great. So it looks like I would say a fairly even split between choices A, C, and E potentially. So, okay, very good.
Slight edge for lowering both insulins.
Slight edge, yes.
All
Excellent.
Right. All right. So what did you do? Don't leave us in suspense.
All right. So don't leave us in suspense. So since he was already elevated at that time, I actually did not make any changes to his insulin, but told him to call me right away if he had any significant changes. And lo and behold, within 2 days, he woke up with a fasting glucose of 48 and called me right away. I instructed him to decrease his Lantus from the 88 that he was on down to 60 units. And then despite this recommendation, he was actually very scared of hypoglycemia, and he himself went ahead and lowered it down all the way to 30 units. And then for the Humalog, I also had him decrease his number of units per serving of carbohydrates. So a very fast response, which really surprised me because I hadn't had very much experience with this at this point.
Davena, this might be a good time to hear from our panelists, actually.
Yeah.
You okay with that?
Absolutely. Would it be good if I stop sharing right now, or?
Yeah, why don't you stop sharing for just a minute? And Bob, can you highlight our panelists, please? Or spotlight?
Yes.
Perfect. All right. So Lenz, you're the senior member here. I'm going to go to you first.
I'm senior. I think I'm senior only due to the hairdo, actually. I think.
I was just looking at you're a professor at Creighton University in Omaha, Nebraska.
Yes,
and
sir.
Right. You're a fellow of ACLM. And you've published over 100 articles and 5 books. So, all right, I guess we'll listen to you. Go ahead.
I wish I had more to say. Actually, what I answered on the poll too was a wait and see. I answered also to not make any changes, and to a bit surprised that he reacted so quickly out of the gate that way. But I think this is such a good example of the communication that can take place between the pharmacist and the patient in managing this, and of course any healthcare provider that's doing this closely. But I think this is a great example of how Davena and the patient work so closely hand in hand, and there was obvious trust there for the patient to say, I woke up in the morning, you know, I have a low reading and I'm going to call right away or connect with her right away to see what to do. So this is a great case so far. I'm you know, love to see how this is. I really enjoy seeing how this is playing out. And I think the level of care that Davena is providing for this patient is fantastic. So so Rohit, what do you got to say?
Rohit, you're on. You got to unmute yourself there. Perfect.
Yeah, I mean, I would do the same thing if I was in your shoes, because you're new to the literature. You truly are coming from a place of goodness and you know, safety for your patient. So you don't want to just willy-nilly change doses without understanding how he's going to respond to these blood glucose readings. So what I do now that I know, now I'm in the know with lifestyle medicine, what I do now with patients is I typically ask them to what extent they're gonna, you know, make the changes. I use a lot of motivational interviewing. And then based on that, I might give them some sort of a range as to how to go about making appropriate changes. And I typically would do that with the mealtime insulin first.
Mm-hmm.
And if I can offer up, you know, just a little more on this one. So part of the case here had the patient look like consistently exercising in the morning for 30 minutes. And so this would be a good opportunity to dive in a little deeper. I know we're going to get to the physical activity part of this case in a minute, but to do some questioning about the insulin administration and the timing of that and the location of that relative to the exercise, because of course we know that there can be pharmacokinetic interactions between exercise and certain medications, and insulin being a prime example of that. If you inject it into a site of a working muscle, then of course changes the pharmacokinetic parameters of absorption and distribution just with temperature and blood flow changes with the shunting of blood into those. So it looked like he was exercising on the bike in the morning. So it wouldn't be surprising to me from the side of, okay, my insulin dropped a ton just with the dietary changes, but then I think it warrants some extra questioning too from that side.
Thank you for that.
Spoken like an exercise physiologist.
Excellent. Dr. Sundermann, what are your thoughts?
So a couple thoughts. One, I feel like I'm like John McDougall. Get rid of all the medications.
Right.
Just stop them all. No, I did select E to reduce both of them. Okay, and I think that's because coming from primary care, practicing lifestyle medicine, in this kind of case, I've seen how quick the changes are, right? And a lot of my patients have gone through TED's Jumpstart program, and the changes are fast. And beginning of your case, Davena, I love your story that you were willing to learn. I think so many times people get into their careers or train a certain way and they stay inside that box. And just what I kept thinking about watching the progression of the medication was Dean Ornish's famous cartoon of the two doctors mopping up that water and getting a bigger mop because there's more water, and getting a bigger mop and recruit more people rather than going to fix the source of the leaky faucet, right? So unbeknownst, and we were all there, right? We all come from a very conventional training, and Bob has been in practice longer than I have, but I've been in practice, 24 years. And for many years, I would have been doing the same thing, just, keep adding on medications. And I think because he was of normal BMI, we're not really thinking, you gotta lose weight, right? Because he was BMI of 22. So that first inclination wouldn't be to look at his dietary pattern. And if you look at his dietary pattern, he is classic what we used to say for our diabetics. You're doing a great job, you're staying away from the carbs, like you're having sandwiches, you're just having the meat without the bread. Good job. Like you're having turkey bacon. It's turkey, it's not pork, so classic what we used to think, or at least how I used to think before taking lifestyle medicine, learning seeing the evidence behind this. And so I think it's great to see your progression, all of our progressions, and then most of all, this patient, and that his changes, and that he was ready. He trusted you already. So you established that wonderful relationship that whatever you said to him and you vetted it, you provided the evidence, because I have a feeling that he's going to be very evidence-based. He's going to want to be objective, and that he followed through with this. So we'll see how this unfolds, but great job.
Yeah, great. Thanks. Dr. Breakey.
Like Melissa, I've been doing this for 37 years and I've seen it happen this quickly. So I also chose cut both. It's better to first be low than high. And Davena, thank you for a great case. This really illustrates several points. And I think that the key point that we're seeing here is that we now understand the mechanism of type 2 diabetes and the intramyocellular lipid. And so he was eating a lot of fat in the form of turkey bacon and eggs and cheese and foods that were gumming up the works. And the analogy there then is if someone's put gum in the locks at your house and you've got the key to get in, it doesn't work. So somebody brings you a bunch more keys, it's like bringing a bunch more insulin. It still doesn't work. And then we enhance the insulin with metformin and all kind of insulin. And then we jazz the pancreas to make more insulin. And we're not getting to the root cause of the problem. Switching from the meat to the beans, suddenly that intramyocellular lipid is the first to mobilize. The insulin starts working and flood of insulin moving into the cells, down out of the bloodstream, brain runs out. Highly uncomfortable. I don't blame him for saying, I don't like this feeling. It's not good at all. So yes, great job in kind of, as Melissa said, all of us were trained that way in medical school and pharmacy school. And now we're recognizing that there is a better way. So awesome that he has you to be able to say, hey, here's a spotlight on something that will work better for you. And now he's experiencing it firsthand. So I'm excited to see what happens with him next.
I was going to add one more thing, just because we're lifestyle medicine and we love our gut microbiome. So when you looked at how he was eating before, right, those poor little gut microbiome microbes are starving, right? And then you increase the fiber. We know that 70% of the immune system and our short chain fatty acids and butyrate and acetate and propionate. So inflammation, including insulin resistance, type 2 diabetes. So by nurturing the gut microbiome, by getting those prebiotics from the fiber, you've just tilted that teeter-totter for him to be all the good organisms to improve his gut microbiome.
Right. So I don't want to stop this love fest, but Davena, put your, let's go back and share your screen again. And while you're putting that up, I just want to mention that Rohit is in Philadelphia. And he's active in leadership at both Association of Diabetes Care and Education Specialists, as well as American College of Lifestyle Medicine, where he's the co-chair of the Pharmacists group. So, okay, we're ready to get back on the case.
Awesome. Well, thank you, panelists, for that incredible input. And so, yeah, continuing his case. So also that day, of course, I provided him a lot of the literature that I had come across. I actually sent him the articles to review. He's very intelligent, as well as some recipe ideas. And so throughout 2018, he had been making some pretty considerable progress, but his A1C was still elevated at 8.2%. And so I know in lifestyle medicine, we talk a lot about the dose of the intervention. And so we decided to up the dose. So he actually agreed to go completely plant-based for dinner. And so example meals that he changed to and actually continues to follow to this day. So breakfast is still a little bit similar, whole wheat waffles with berries. So he added in some fruit with breakfast, considerably decreased how much turkey bacon he's having. For lunch, an example might be cod. He added in those refried, fat-free refried beans, raspberries, cranberries, and dinner looks like salad greens, carrots, garbanzo beans, kidney beans, and berries. And he actually absolutely loves fruit and loves his berries and is so excited that he can actually eat those now. And he has them almost with every meal. And just an example, I just calculated out an example macros for one of his days. So now he's up to about 175 grams of carbs, about 55 grams of protein, and he's easily hitting that target for fiber, about 46 grams of fiber a day. So we really flop those macros considerably. And again, back, in my previous knowledge and experience, I would have thought, wow, that's a lot of carbohydrates in a day. So what happened as a result of that? So I'm excited to show this next slide. So here's his hemoglobin A1C and what it has done. And so the two arrows that I put in were the time frames of which we made those dietary changes. So the beginning of 2018 was the first, and then kind of the end of 2018 was the second. And as you can see, really since 2019, his hemoglobin A1C has consistently been at goal of less than 7% and really pretty consistent. He did have a bump up a little bit in May of this year, and actually he does attribute that to some decrease in his physical activity compared to what he was usually doing. And so we talked about that, and he was able to course correct a little bit more. And his last A1C back in November came back at 6.6. And so speaking of the DipACLM, you might be curious what medications he's currently on. So you can recall he had got up as high as 88 units of Lantus. He's now using somewhere between 18 to 20 units of Lantus at bedtime. He adjusts that a little bit depending on his day. Humalog, he's doing 4 to 6 units before meals. He's still on metformin. Of course, I stopped the aspirin, especially given the trials that came out regarding aspirin for primary prevention. And very importantly, he no longer has these significant fluctuations in his blood glucose and is no longer having hypoglycemia. So despite his hemoglobin A1C now being much better controlled and at goal, he's also no longer having hypoglycemia. And so he's, of course, very happy. He's been very stable for a while. And so it kind of raises this question, I think, we've got him almost to the finish line, right? He's made some really wonderful changes. We've almost got him. But how do we get him completely there? And I want to open this up to the panelists to kind of address this question. And thinking about it, if I were to be able to convince him to go completely plant-based, what do you think would happen? Do you think we could potentially get him all the way off mealtime insulin? How might you approach this case? So I'm going to stop sharing, and if it's okay, go ahead and open this question up to the panel as well.
Yeah, absolutely. That's great. Thank you. Well, I'm going to actually go to Dr. Sundermann first, since she was channeling Dr. McDougall, and then I think we'll go to Rohit and Tom. So.
Yeah, I mean, I feel like this patient, you should go for further deprescribing, right? And really exploring, the turkey bacon, does he really need to have that? And fine tuning, refried beans, could he just do black beans instead, getting rid of some of the added oils? Because he's already, and just like you said, supporting him, giving him cookbooks and things like that, don't think about what you're giving up, think about what you're gaining. And if he could get off of injecting himself and taking metformin, maybe, that's a way to approach it. I mean, and we know that remission of type 2 diabetes is entirely possible. I think that, what you'll need to figure out is, could he possibly be a diabetic on 1.5, right? And in that case, sometimes patients do need to stay on a metformin. But curiosity, did you ever have like insulin levels checked? No, okay. Because that would be, as you go further, and if he goes more and more plant-based, and compliant and stays up with his exercise program, that if you're trying to deprescribe, maybe looking what that insulin resistance level is, that might be important information to decipher whether he truly is a classic type 2 or whether he's a type 1.5. And that could be, if you're kind of hitting a plateau and he's a 1.5. But he's made tremendous progress. So maybe just saying, look how far you've come. And now it's just fine tuning, right?
Yeah. Dr. Moghe?
Yeah, I had a situation like this happen with a patient a couple of years ago. And, we were just at the finish line, just not there yet. Her A1C went from 10 to 7 in a matter of 3.5 months. And I said to her, especially since ACLM had put out the remission in type 2 diabetes, I said, there is a number we can get to. If we can keep you there, then we can possibly say your diabetes went into remission. Would have to work with your primary on this, but you're almost there. Now, in her case, she was the only medicine she was on was an SGLT2 and metformin. She was not on any insulin, but she had made a significant amount of dietary changes. Her only animal-based food was dairy, but it was very minimal. So she just needed to tweak it a little bit more. So, I've used motivational interviewing in her, and she's like, I'm in a happy medium right now. I'm going to keep working at it, but at the same time, I'm not there just yet completely. And I think one of the things that was contributing to her high A1C just kind of hovering around 7, like 6.87, was the fact that her sleep was horrible. She was off for Ambien as a part of a whole DipACLM, but her sleep was horrible. So I was working with her on, addressing her anxiety that was preventing her from falling asleep. So, I like the fact that you were able to sustain his A1C below 7. So you've gotten him to ADA goals for sure. He's almost there at the ACE goals. And if we go tweak it just a little bit more, we could get him to remission. Now, the ADA did put out a statement, not too long ago, and they said that remission could happen if your A1C is 6.5 or less for 3 months, which I thought was a provocative statement by them. And I thought the ACLM definition was more realistic along the lines of remission.
And the ACLM definition is under 6, right?
It's 6.1, I believe.
6.1. Okay. Yeah, and I think actually, but I think that they issued a statement that 6.5 was good enough, and so we actually have a paper in the works that we revised because of that, which we haven't had published yet. But so, Dr. Lenz.
Yeah, no, I love the question on this, Davena. So how aggressive, how far do we push on this? Considering we've already made some great progress on deprescribing, this is a great patient to keep going. You have a motivated patient. You have a patient that likes, as you said, likes the numbers, is going to already connect with you. And if something, isn't going right. So this is, I think a great patient that that is going to be adherent to recommendations and is going to work with you really in a partnership type of way. So you already have a really good setup to keep going and see what this looks like if you continue to push a little bit more aggressively with this. And I think the story itself is a really good one as far as what we have, where we started from. As we've said several times, that knowing carbohydrate had so much emphasis on our education, and then what we've learned through the way, and working with individual patients like this. And this is a great example, I think, of being able to, as a pharmacist, which we don't always get to do, but working closely with an individual, making a change and then getting the feedback right away. Because that doesn't always happen for us. A lot of times we're giving information and then the feedback goes somewhere else to another, to somewhere else on the team. But this is a really great example of how feedback really helps with the learning, process for pharmacists. And I had, a very similar experience, to something like this that was a wow, as a ground zero patient for me as well, that helped me to say, okay, I got to dive into literature and find out more. And it's only because I was getting immediate feedback, just as you were here. So I think that's a great kudos to you and how you went through the process.
Yeah, I second. That's great. So before I turn it over to Dr. Breakey for his thoughts, I just want to note that somebody in the chat has said, sign up for Jumpstart. So I don't know if you're familiar with our 15-day whole food plant-based Jumpstart, but somebody like him, who's obviously an intellectual, right? I think he'd probably find it pretty interesting to see, be on the screen with 30 or 40 or 50 other people just to hear their stories. And so, anyway, Dr. Breakey.
So I also agree that this is a great place to give him the option. through motivational interviewing. You see if that's what he wants. Maybe he's happy with being at ADA goals and not having big swings, and that's all he's going to do. But I want to make sure that he's still eating turkey burgers and fish because he really, really likes it, not because he thinks it's good for him. And I pull up this picture for people to be able to say, you know, chickens are now a high-fat food. And I put it right on my computer. They used to be, you know, back in the 50s, 2 or 3 grams of fat per chicken breast, and now it's 20. So this is like red meat now. Don't be confused about that. Turkey, bacon, and others. And then we talk about the fish, and I say, this fish is very high in animal protein, which stimulates IGF-1. And even if your diabetes is better controlled, you're putting yourself at higher risk for cancer. What a shame to get controlled diabetes and end up losing your prostate or your colon. So you're treating a symptom in a manner with that insulin to make it look like everything's fine, but underneath you're getting these other concerns. The other thing about fish, of course, is the environmental and other contaminants. And I had a good analogy to help people get over the fish hump the other day. I was making a smoothie in my Vitamix, you know, throwing in the kale and the banana and the berries. And I said, what if I dropped a plastic fork in here? And would I still drink that smoothie? Well, there's so much microplastic now in fish that eating fish these days is the equivalent of having a smoothie that you just dropped a plastic fork in. So I think that comes to people to say, well, even if it has healthy omega, and even if somebody's telling me fish is good to eat, I don't want what comes with it. And that may help him to be able to say, okay, I'm going to go that next step with you. Now, again, he says, don't talk to me about that. I like these foods. I don't care what you say. I think they're good for me. That's okay. You know, I can manage the medicines. You're way better than you were. But I think everybody deserves the option. I hate for him to come back later, find out that true reversal was possible and say, wow, why didn't you at least give me the option? That's my approach.
That's great.
Nick, can I ask a
Thank you.
question? So PCP referred this patient to you. You've been working with this patient. What has the PCP had to say? And so you've now disrupted this whole myth, right? That a low carb diet is going to fix them and medications are going to fix them. And you've switched his diet, and then you maybe even suggested he consume soy, and soy is cancer forming. So this is how we spread our wings within lifestyle medicine, right? Because probably this PCP, I'm going to make an assumption here that probably is not well versed in whole food, plant-based and lifestyle medicine, how we approach this. Have you had correspondence back to the PCP, and what were the thoughts? And are you educating? Are you able to educate?
Yeah, I think that's a fantastic question. And yes, absolutely. I kept her updated on this whole process, and she was surprised like I was, but very, very open to what was going on, and just very pleased that her patient was getting much better. So yeah, she was very open, and I think you bring up a really good point, so that it's an opportunity for us to educate and work with our colleagues to use patient examples to spread the word and education.
Yeah, it's fascinating hearing how the roles are changing so much. It looks like Ronnie has just turned on her video. Did you want to introduce yourself? Did you have a comment or a question? You're muted, so you're muted. We're not hearing you.
I don't have any question. I'm a second-year family medicine resident. I work with Dr. Norris.
Oh, okay, great.
Yeah.
And so you're learning from her.
A lot, yeah. I enjoyed this presentation. It was wonderful.
Oh, okay. Well, thank you for that. I mean, it is fascinating to think about how roles are changing, and you know, some of this information doesn't seem like medicine, right? That's why insurance companies don't want to pay for it, because it's not really medicine. In fact, you guys are pharmacists telling people how to eat, right? Well, that's great. I mean, Dr. Lenz, you've seen the changes over the years. Could you just comment how the roles have been changing?
Yeah, you know, we started our lifestyle medicine program, pharmacist run lifestyle medicine program, in the middle 2000s at Creighton. And it was tough sledding, you know, at the beginning, because lifestyle medicine, first of all, was a very new language and most people didn't really recognize what it was. But then also there was a lot of feeling like we were stepping on toes. This is my territory, and even if you're talking about lifestyle, just dispense the medication and just let us do the work. And so, yeah, I think the education around this space, even in ACLM, has been wonderful to see. I mean, in the early days, it's almost exclusively physicians, and now to see it blossom and to see the interprofessionalism take hold, and now what we're witnessing, at least around our space, is that people want to be involved from an interprofessional side, and we have clinic space that's designed for this type of thing, and we have people who have lifestyle medicine as their specialty in that clinic space, and as a team member to contribute. But at the same time, we're seeing not just pharmacists, we're seeing dietitians in there, we're seeing social work, we're seeing all kinds of people into that space, and the care for the folks is from the metrics we're following is getting enhancing a great deal, as is the quality of life of and the experience, patient experience.
That's great. Yeah, Bob.
Yeah, Ted, we have now embedded pharmacists in most of our primary care offices at IHA, and it's awesome. The partnership there helps to bring help with polypharmacy, to help education, to assist. And a lot of this is now seeing this, as you all are doing, is marrying lifestyle medicine with this. Takes me back to an IHI conference from 20 years ago with a presentation on the Asheville Project. In 1997, they launched a project where they partnered with pharmacists, and a lot of it there was just, hey, get your gold card, to talk to your pharmacist about, and a lot of it was medication compliance then, but about all aspects of diabetes care, and you'll get to have continued no copay on your meds. And that was so valuable to people that they would actually do it. And that partnership blossomed. And so I'm glad to see this now kind of happening in your group, in our group, and many groups now, saying that we pharmacists have so much more education to offer than just dispensing meds. So thank you for being here tonight, for presenting, for being a part of the lifestyle medicine team, because I may have been at that same ICNM conference where the pharmacist presented, where you got your teachable moment there from your switch over. But they have so much more to offer in this field as well, where you have that contact with people at that moment, and where you can help them to see that it is possible. And the kind of center party line is that pharmacists are all about the medicine, but enlightened ones like you, just like enlightened physicians, are really recognizing that, yes, there's a place for it, but it should be as a secondary, as like most of our guidelines say, hypertension is not a disease, it's a condition caused by chicken and cheese and eggs and salt and potato chips. And if you get rid of the cause, you won't even need this level. One other quick comment, as Carrie mentioned, we should get a C-peptide in this patient, because it is possible that they will require small doses of insulin. Being normal BMI makes me highly suspect that they're type 1.5, but the amount of insulin could be lowered even further. I commonly see just 6 to 8 units in these folks if they're eating whole food plant-based. And in addition, it helps them reduce their risk of other conditions, including future Alzheimer's, cancers, strokes, heart disease, et cetera. So.
Absolutely. No, yeah, thank you for that. Rohit, I was about to call on you and you raised your hand, so go for it.
Yeah, we're having such a phenomenal conversation that, like Dr. Breakey said, you have pharmacists embedded in your clinics. And I see that within Trinity in the Michigan region, both on both sides of Michigan. We're trying to build that here in the Philadelphia area. And these are prime individuals where you can give them a tickler. Is like, hey, I know you're working with me on chronic disease management. To what extent would you be interested in seeing how many of these patients we can get off the medicines? And maybe you're interested in lifestyle medicine. So that's a tickler for you guys as the physicians and the providers to bring more of us in. But I also wanted to share that both Davena and I commiserated at the conference that we're the only ones in our clinic or in our work environments that think this way and actually do practice this way. And we actually need physician champions to kind of help us move that that needle further along. I can't tell you how many times you know, physicians in my practice are writing in the medical record, advise patient on a low carb diet. And I'm like pulling my hair out. That's why I have less hair now.
Right.
So like, I have to figure out a way to reverse that, that thinking. So I have to figure out, not only do I need a physician champion, but we also need to educate them that there is a better way. We don't need all these medicines for any reason. So that, I think that's really the power of collaboration, bringing people along, because at the end of the day, in this interprofessional world that we're in, we're all here to help one another. You know, we're not trying to take anything away from anyone. We're just trying to make it better, or trying to enhance it in whatever way we can in a team-based way. And to Dr. Breakey's point, Davena does have some slides that show the impact of pharmacists in diabetes care. Mind you, the big flaw here is that they're not necessarily using the 6 pillars of ACLM all at once. They're using aspects of it. And some of the data doesn't necessarily show, you know, long-term impact the way Davena showed with her patient. So these are slides. This was a systematic review. Over 5,000 patients were included in this systematic review that showed 11 of 13 studies. A pharmacist, you know, led improvement in glycemic management and medication adherence. You see an average A1C drop closer to 2% with pharmacist involvement. So this kind of solidifies the Asheville project that Dr. Breakey was talking about. And then the next slide, you know, kind of takes it a little bit further, that you're getting more people less than 8. Now, 8 is basically your NCQA mark. We know we can do better than that. So the 8 is basically what insurance companies want you to be at, even though that's not necessarily what the medical guidelines suggest, whether you follow ACE, ACLM, or ADA. But this is kind of like, you know, what the insurance companies give you, that wiggle room. And then the next slide shows the endurance of these, of the A1C reduction. They go out as far as 6 months. Davena demonstrated that she's gone out almost 2 years, or actually over 2 years with her patient. And I think that's a very powerful message, that, you know, if you're able to figure out how to get the pharmacists involved, not only who know the meds and which meds the patients need to be on, but encourage them to figure out a way to deprescribe and get patients off unnecessary meds, man, you got yourself a very powerful ally there.
Yeah, no, thank you for that. It's a powerful message. And looks like we had a mutiny. We went into overtime, but that's okay. That's okay. I'm grateful for that. What we're going to do is we're going to officially end this, and then we're going to move into the lobby. And because I think we have a good conversation going on here. And when I say the lobby, everybody can stay where they are. It's a pretend lobby. So those of you who have to leave, we understand, out of respect for your time, that this is officially over. You will be receiving an email with a survey. And if you fill out the survey, you'll then get be able to download your CME certificate for 1 hour for having attended tonight. So we're very happy about that. And I'd like to thank Bob Franke, who has been our engineer in the background, and Brian Bell, who's also been making sure that everything works in the background. And just before we continue, because we're going to continue, I just want to remind people that we do offer some other free CME programs, including, I know we have an enthusiastic supporter of our Jumpstart. Let's see, it's Dr. Deborah Kluger, I guess. Did I say her name right? Anyway, she was recommending that people go through the Jumpstart. If for clinicians who go through our Jumpstart, you will get 10 CMEs actually just for attending. And it's part of a bigger program also that if you take the didactic part of it, you can get another 14. So it's actually 24 hours of CME credit. You can also get 10 hours of CME credit for going through our LIFT program. But we love it if you go through Jumpstart and send your patients, because the patients like Davina's can really benefit from that type of thing.
Kind of bit of a topic, and I kind of want to get everyone's opinion on this. So I switched positions and I'm at a unique role now, and we are using continuous glucose monitors on some guests and patients that want to, we're not dealing with insurance, so people pay to have these on. So here is my frustration. So majority of these, they're not diabetic, right? They're just tracking their glucose and they want to stay within range. We gave them a range, and they get freaked out because when they have a banana, their glucose goes up, right? And so we have nutritionists, and so they counsel about wanting to keep that glucose within that range. And guess what's not going to bump your glucose? The turkey bacon, the fish. So I try to counsel the patients that we're talking about insulin resistance, right? And educate about the intramyocellular fat accumulation, that even though, you know, yep, you're right, a banana is going to cause that, but that's because you're insulin resistant, right? And if we can get the insulin resistance better, we won't see those spikes. And it's normal, right? To have if you have something that has a carb, you're going to see a spike, and then it should normalize. So it's okay to have these. And I think that when my fear is that when the patients have these CGMs and they're looking at their readings all day long, they're going to want to do the best they can. And that's going to be really sticking away from the carbs that are so good for us. I'm fine if they cut out their Krispy Kremes and their bagels, but, you know, don't cut out your sweet potatoes. Don't cut out your berries. You know, someone had watermelon and they're like, oh my God, I can never have watermelon. So tell me what you guys have had experience with, because we're going to see more and more of this. As before, it was just CGMs for type 1 diabetics, but now all this like artificial intelligence and personalized medicine and monitoring. We got our Garmins, we got our Whoop, got our Oura rings. It's coming down the road. And how should we best address this as talking points, that it's okay to have your sweet potato and a watermelon?
Yeah.
Go ahead, Bob. What a break.
No, aside from all right, go ahead, Doctor. Well, I want to hear from everybody else, but Dr. Breakey, you go first.
Of course, this is a classic example of vilifying the wrong thing. Blood sugar going up after eating is normal physiology. That's like saying I exercise and my pulse goes up. Uh-oh, I'm tachycardic. I better not exercise. That's just normal. Your blood sugar goes up while you're absorbing it. The insulin is released in response and titrates it into the cells like it's supposed to. So this idea that we have vilified the wrong thing needs to be brought into spotlight. Yes, diabetics who spike up to 240 because their insulin isn't responding at all, that's not right. And nor is it if someone gets into SVT and gets a tachycardic of 180 when they're resting. But exercising, high pulse, eating, high sugar, normal.
Yeah, I agree. Ted, you're muted.
I was just going to point out that Dr. Lenz is unmuted, so he must want to talk. And then I want to hear from everybody else as well, but go for it.
I never muted myself in the first place. So I guess
okay.
No, so I think, Melissa, what you bring up is the larger point of patient care, which is really societal and cultural issue about perfectionism within care, within healthcare in general. Okay, so, we're used to being trained of, well, the patient's apathetic, they really don't care about, so we really got to motivate them and get them, to really do this thing like exercise and eat, in a different way, and to follow this new way of doing things. But and of course we still have that, but there are many folks now, more than what I would say 20 years ago, had that latch on to this notion of perfectionism within their readings. And we used to, in the good old days, give them a lifestyle journal, as a lifestyle medicine journal. and they would track everything. Everybody get a home blood pressure monitor, and that was back when you wore a pedometer, and so they'd track all those things. And this goes back, I think, maybe 2007 or so, and it was really working well. And I had this individual who was a numbers guy, and he actually went backwards with this because he could not handle if he didn't hit the mark on everything. So I think it brings up a bigger issue, and certainly one for a larger conversation than this, about talking with our patients about what it means to have a little bit of a little bit, and what a little bit of latitude, but what that means within the range of their specific. And do you have to hit the mark every time? Do you have to be perfect every time? And that, I think, brings up the larger issues, which we talk a great deal with our patients about now, about chronic stress related to those particular things, because we see it so prevalent now. And as you said, all people wear the the Oura rings and have all kinds of devices, the watches and so forth, that measure everything so tightly. So I think we're analytic and data overloaded. It serves a great purpose, but we also have to keep it in check, and so that's something we have specific conversations with our folks about.
Yeah. Davena, you have any comments? And then I want to hear from Rohit one more time before we wrap it up. So Davena,
Yeah.
your thoughts on that?
Yeah, sure. So, I mean, specifically related to the CGMs, I'm frustrated because actually many of our insurers who I really want patients to have a CGM, I have a hard time getting them approved. So I'm not running into it as much, but I think it's a very good question. And then I commonly encounter, when you start making changes for people who have significant insulin resistance and they eat their first banana and they see their blood sugar spike up, and then they say, I'm never going to eat a banana again. So I think that having that conversation, and I think there's also a few strategies on how to reduce that, maybe when initially transitioning over, maybe perhaps utilizing some of the higher fiber things like maybe beans or something that's has a little bit lower glycemic index initially, to try to minimize those spikes while the underlying insulin resistance is being corrected, might help. But I commonly see that when they have their first banana, it spikes up and they never want to have it again.
Yeah. Interesting. So Rohit, you were the spark for this. Speaking of sparks, you were the spark for this whole event tonight, Lifestyle Medicine Grand Rounds with Pharmacists. So do you have any parting thoughts?
Well, first of all, I really do appreciate, having the platform for pharmacists. Again, my duty as the co-lead of the pharmacist member interest group at ACLM is to, put the spotlight on the stars that we have. And we do have a lot of great stars, like Tom and Davena. Parting thoughts, kind of commenting on the question Melissa asked regarding CGMs. We do need some data out there showing how powerful CGMs are when people are transitioning to a whole food plant-based diet. I believe one of our pharmacist members, Denise Fields, was looking to do a study on that. In our clinic patients. I don't know where she is along that. But yes, we definitely need to add whole food plant-based dietary pattern and CGM as a knowledge base. What happens when you go this way? And compare that to what was happening before you went this way. And that's power in itself. Like, those are numbers that people are going to see, oh, my numbers are actually better even with the CGM and eating the banana. On the flip side, you could get cheeky with a patient like the one Melissa was talking about with going crazy with the bananas and the blood sugar spikes. Hey, let me do a lipid finger stick on you and show your triglycerides after eating a turkey bacon.
You would never do that though, right?
Why not? But we'll be cheeky. It's okay.
Exactly. Sounds good to me. Sounds great. All right. Well, with that, bit of pharmacy humor, which I appreciate greatly. I'd like to thank our panel, our regular panelists, Dr. Breakey and Dr. Sundermann, our guest panelists, Dr. Lenz and Dr. Moghe, and our incredible presenter, Dr. Davena Norris. Thank you all. And Dr. Freeman, I know you're in the background, so thank you to you as well. And if you haven't, don't forget to fill out the survey that you'll be should have already received, and you'll get your CME. And this will be available as a video in the next week or so on our YouTube channel. And everybody's invited to watch that, including people from the general public. So thank you all again. And Bob, thank you for your service. Right. Bye.
Bye.
Thank you all so much.
Good night.
You're welcome.
Good night.
Good night.